ENT Competency 4.8 Elicit, document, and present a correct history, demonstrate and describe the clinical features, choose the correct investigations, and describe the principles of management of squamosal type of CSOM by ENT student. It is going to cover knowledge and skill domains. The level of learning is shows how. It comes under core competency. Suggested teaching learning method lectures, small group discussion, dope session, bedside clinic. Assessed by written, viva, skill assessment. What is squamosal type of CSOM? Chronic otitis media is of two types mucosal disease, squamosal disease. Squamosal disease is again divided into two types retraction pockets in pars tensa or pars flaccida, also called atelectatic ear. This is inactive type as it is associated with no discharge. Active cholesteatoma with discharge. It is squamosal type of disease of middle ear cleft. It mainly involves posterior superior part of middle ear cleft associated with cholesteatoma. Unsafe type because of bone eroding properties. High risk of serious complications associated with an attic or a marginal perforation. It is also called as aticoantral type of CSOM. Chronic inflammatory conditions of the middle ear cleft confined to posterior part of mesotympanum, attic and antrum associated with bone eroding disease or cholesteatoma characterized by thick, purulent, scanty, foul-smelling, blood-stained, persistent discharge and may be associated with perforation in pars flaccida. Case of squamosal type of CSOM. Patient Y, 52 years old male, comes with chief complaints of discharge from right ear since 15 years, reduced hearing in the right ear since 10 years. Discharge was scanty, mucoid, blood tinged, foul smelling, not aggravated by exposure to cold, URTI, and relieves on medication. Last discharge was 4 months back. Reduced hearing since 10 years, no history of itching sensation, vertigo, nose or throat complaints. On examination, there was a presence of attic perforation. Rennie's test is negative in right ear, positive in left ear, which is normal. Weber's test lateralized to right ear, absolute bone conduction, same as examiner. Retraction pocket. Invagination of tympanic membrane in the attic or posterior superior area of pars tensa. It is of four stages. First, mild retraction. Second, contacts the incus. Third, middle ear atelectasis. Fourth, adhesive otitis media. Cholesteatoma. The middle ear cleft has different types of epithelium at different regions. Ciliated columnar in anterior and inferior part, cuboidal in the middle part, pigment like in attic. Cholesteatoma is skin in the wrong place, that is, presence of keratinizing squamous epithelium in the middle ear cleft, also called epidermosis or keratoma. There is a term called cholesteatoma here, where cholesteatoma bridges the gap caused by destroyed ossicles. It consists of two parts matrix, made of keratinizing squamous epithelium resting on a thin stroma of fibrous tissue, central white mass consisting of keratin debris. Cholesteatoma destroys bone by collagenase, acid phosphatase, and proteolytic enzymes liberated by osteoclasts and mononuclear inflammatory cells. Keratin mass surrounded by matrix of stratified squamous epithelium surrounded by fibrous stroma and bone. Theories of cholesteatoma formation. First one, congenital cell stress. Second, invagination theory by Whitmack. Invagination of tympanic membrane from attic or posterior superior part of pars stanza. Third, epithelial invasion theory by Haberman. Squamous epithelium of tympanic membrane migrates to middle ear via tympanic membrane perforation. Epithelial invasion through posterior superior perforation. Fourth, basal cell hyperplasia theory. Infection or inflammation. Basal membrane breaks. Squamous epithelium invade into subepithelial tissue and pars flaccida like epithelial cones forming microcholesteatoma. This enlarges and perforates secondarily through the tympanic membrane. Fifth, squamous metaplasia theory. Cuboidal epithelium can undergo metaplasia to squamous epithelium. Middle ear cuboidal epithelium is pluripotent and can be stimulated by inflammation to become keratinizing squamous epithelium. Types of cholesteatoma. Cholesteatoma can be of three types. Congenital cholesteatoma. It arises from the embryonic epidermal cell rest in the middle ear cleft. It occurs in the middle ear, petrous apex, and CPA. Presence as white mass behind tympanic membrane with CHL. Primary acquired cholesteatoma. No history of previous otitis media or perforation. It occurs as a result of tympanic membrane retraction. As the membrane retracts, the cholesteatoma can erode into ossicles and erode into the adductus antrum and mastoid. Secondary acquired cholesteatoma. There is already a pre-existing perforation. Haberman's theory. Epithelial invasion through a pre-existing perforation. Sadie's theory. Metaplasia due to repeated infections. Differences between tubotympanic and aticoantral type of CSOM. Tubotympanic is also called safe type. Aticoantral is unsafe type. Discharge in tubotympanic is profuse, mucoid, odorless. It is scanty, purulent, foul-smelling in aticoantral type. Perforation is central in tubotympanic, attic or marginal in aticoantral type. Granulations are uncommon in tubotympanic, common in aticoantral type. Polyps are pale, red and fleshy in aticoantral type. Cholesteatoma is absent. Cholesteatoma is present in aticoantral type. Complications are rare in tubotympanic, common in aticoantral type. Audiogram. Mild to moderate conductive in tubotympanic, conductive or mixed in aticoantral type. Clinical features. Symptoms. Ear discharge. Scanty, foul smelling. It is due to erosion of bone. Hearing loss, mostly conductive. Bleeding from granulations and polyps. Signs. Perforation, either attic or posterior superior marginal. Retraction pocket. Cholesteatoma. Pearly white flakes. Investigations. Examination under microscope. Ear discharge swab for culture and sensitivity. Pure tone audiometry to assess hearing loss. X-ray mastoid. Bilateral 30-degree lateral oblique, also called as cellular view. CT scan. Revision surgery complications in children. Examination under microscope to confirm otoscopic findings. Site and size of perforation. Margin of perforation. Appearance of middle ear. Presence of polyp and granulation tissue and its site. Attic retraction pocket with cholesteatoma formation. Eardrum. Uses of X-ray mastoid. Position of dural and sinus plates can be known. Type of pneumatization: cellular 80%, diploic 20%, sclerotic 20%. Cholesteatoma appears as cotton wool. Bone destruction: presence and extent. Mastoid cavity. Complications of CSOM, aticoandral type. Pain: it may indicate extradural, perisinus, and brain abscess. Vertigo: indicates erosion of LSC. Persistent headache. Intracranial complication. Facial weakness. Erosion of facial canal. A listless child refusing to take feed and easily going to sleep. Extradural abscess, fever, nausea, vomiting. Irritability and neck rigidity. Meningitis. Gardner syndrome is a classically described as clinical triad of otitis media, facial pain, and absence palsy that in the past most commonly developed from infection in petrous temporal bone. Treatment options: medical. It is of conservative type. Topical ear drops plus frequent suction clearance. Indications: early disease with shallow retraction pocket. Only hearing with cholesteatoma. Elderly patients. Patients who are not fit for surgery under GA. Patients who can regularly come for follow up. Surgical treatment: mainstay. Canal wall down. Type of procedure: aticoandrostomy, modified radical mastoidectomy, radical mastoidectomy. Canal wall up. Combined approach tympanoplasty, CAT. Surgical procedures: myringoplasty, an operation performed to repair or reconstruct the tympanic membrane. Tympanoplasty, an operation performed to eradicate disease in the middle ear and to reconstruct the hearing mechanisms without mastoid surgery, with or without tympanic grafting. Ossiculoplasty, an operation performed to repair or reconstruct the ossicular chain. Case 2 diagnosis: a right chronic suppurative otitis media, aticoandral type, discharge in inactive stage with conductive hearing loss, not associated with any complaints. Thank you.